Thanks for your interest in covering the meeting. We know that you play a key role in disseminating the crucial information that's presented here about lung cancer research, clinical trials, new treatments, and about our patients, like Dusty there at the end. While immunotherapy and targeted therapy are very much the main attention getters at this meeting, this press briefing is a nice reminder, I think, that lung cancer is a complex disease that has very far-reaching impact on our patients. We will indeed have two great talks about immunotherapy in both non-small cell lung cancer and small cell lung cancer. But you also hear about methods to improve informed consent, such a basic but foundational and essential aspect to enrolling patients in clinical trials. I'll give a brief aside that this was very poignant for many of us medical professionals as we went on a Vienna hot rod tour organized by Dr. Stephen Liu there. We were given a form to sign that was consent. It was all in German. We all dutifully signed it, had no idea what we were signing up for, what kind of danger. And I sort of liken that to the process, I think, for patients who sign up for these complex clinical trials. And so it'll be interesting to hear about that in the patient perspective. We're also going to hear about sexual health, and that's something we don't like to talk about. That's uncomfortable for a lot of medical professionals. But Dr. Flores is going to share an update from the Shaw study on sexual health among lung cancer patients. I think a really important topic that will be of interest to the lay press as well. And it's worth noting that we're also featuring another presentation on the connection between air pollution and lung cancer. Clearly, you're hearing a lot of talks about the rising incidence, or at least the perceived rising incidence of lung cancer in never smokers. And we certainly believe that air pollution is one of those links. And more researchers are examining the role that pollution plays in lung cancer. And these findings are often quite troubling. So please hold your questions until the end of the briefing, or feel free to type them into the chat box, and we'll be sure to read them to the appropriate researcher. A video recording of the press briefing will be uploaded to the website later today for easy reference. So I'd love to introduce our first presenter, Dr. Renelle Myers, who will present evaluation of outdoor air pollution in female non-smoking lung cancer patients. Dr. Myers is a clinical associate professor of medicine at the University of British Columbia, an interventional respirologist at the Vancouver General Hospital. She's the lead for the BC Cancer Smoking Cessation Program and the principal investigator of the Lung Breathomics Lab. Dr. Myers.
Well, good morning, and thank you for the invitation to present our work. Thank you for the introduction. I'm going to be talking about our work performed in Vancouver, Canada, about the evaluation of outdoor air pollution exposure, specifically to PM 2.5 in female non-smoking lung cancer patients. So more females than males who never smoked tobacco have lung cancer. And in fact, the number of lung cancer in patients who have never used tobacco is anticipated to be higher than people who have used tobacco over the next 25 years. Air pollution is a major cause of lung cancer in people who have never smoked tobacco. And in fact, the global burden of disease has accounted for 15% of all lung cancers, secondary to PM 2.5, second only to tobacco. The effect of air pollution may take 15 to 20 years to be reflected in lung adenocarcinoma incidence rates, and the duration of past exposure to PM 2.5 relevant to the assessment of lung cancer risk has really not been characterized. And that was really the objective of our study, is to look at comparing the cumulative 3-year versus 20-year PM 2.5 exposure in female patients who have never smoked but were newly diagnosed with lung cancer. And I just want to briefly describe PM 2.5, which is the particulate matter in air pollution that is 2.5 micrograms or less. And that's what I'm going to be referring to. So all females that were newly diagnosed at the BC Cancer Centre in Vancouver, Canada, as well as a thoracic surgery clinic who had never smoked tobacco, were asked to participate in this study. They underwent a very detailed residential history, and this allowed us to track their entire lifespan from their current address dating back to where they were born and input this into a geographical information system. This was very granular data. We needed postal codes from each address, and this allowed us very accurate linking with satellite PM 2.5 data that dates back to 1996. We have very accurate satellite data from 96 going forward. We then created a model that we were able to quantify the cumulative exposure to PM 2.5 with high spatial resolution. And we compared the magnitude of a 3-year versus a 20-year exposure. So this was the cohort. We were able to recruit 236 female patients who were newly diagnosed with lung cancer. As you can see here, the majority were Asians at 71.2%. The majority were also born outside of Canada, with foreign-born being 79.7%, and the country of origin most commonly with greater than 51.1% from China and Hong Kong and the rest of Asia. 92.8% had adenocarcinomas, and unfortunately, 56% were a later stage 3 to 4. We had a very high EGFR mutation rate at 46.7% in this cohort. And so when we look at the 3-year versus 20-year weighted cumulative exposure to PM2.5 in this group, when we look at the 188 foreign-born Canadians, if you look at just their 3-year exposure, and I don't have a, pointer, but if you look at their 3-year exposure, only 2.1% would have an exposure of greater than 10 micrograms per cubic meter. But if you do a 20-year cumulative exposure, 20% have an exposure greater than 10 micrograms per cubic meter. And this is statistically significant. Of note, only one participant actually had a PM2.5 of less than 5 micrograms per meter cubed, which is actually what is recommended as if we know a safe exposure rate by the World Health Organization. Oops. Press F5. Thank you. Nope. Okay. Sorry about that. Because we had such a high incidence of EGFR mutation in this cohort, we wanted to see, was there an association with the level of PM2.5 exposure and EGFR? And in fact, there was a significant association with EGFR mutation in the 3-year cumulative exposure. Interestingly, this was lost in the 20-year cumulative exposure. So higher PM2.5 exposure in patients with EGFR mutation was only observed in that shorter term exposure comparison, making us think that perhaps this could be a promoter. The significance of this study demonstrates, sorry, it's like on an automatic thing here. Okay. Yeah, it's a little challenge. Thank you. So the significance of this study really captures that short term, or at least less than 3-year cumulative exposure risk for PM2.5. We'll probably underestimate the adverse health effects that chronic exposure to air pollution has, especially among patients who have lived elsewhere that may have had higher exposure throughout their lifetime than where you actually meet them. And I just wanted to draw your attention to the figure here demonstrating the mortality associated with PM2.5 and the risk ratio that goes up over time. It's more accurate at least at 8 years of cumulative exposure. And you can see that over time we have national committees and the World Health Organization has been rapidly reducing what we feel is a safe exposure. And I'll point out that it's now 5. When we did the study, it was 10, and that's why we chose 10 micrograms per cubic meter as the cutoff. And so it'll be interesting to see now when we lower that where patients fall. So I want to thank our sponsors, but who I really want to thank are the patients who volunteered for these lengthy questionnaires at a very difficult time on their cancer journey. Usually it was the first appointment at the cancer center. So thank you to the patients who made this possible.
Tremendous. Thank you, Dr. Murray. Sorry about the AV issues. It's my pleasure to introduce Dr. Solange Peters, who will present her study of the association between KRAS, STK11, and KEAP1 mutations and outcomes in Poseidon, durvalumab plus tremelimumab plus chemotherapy in metastatic non-small cell lung cancer. Dr. Peters needs no introduction, but she's the professor and head of medical oncology at Lausanne University, where she also leads a translational program in collaboration with the molecular oncology laboratories.
On behalf of my co-author, it's my pleasure to be able to discuss with you these data looking at the association between KRAS, STK11, KEAP1 mutations and outcomes in the phase 3 trial Poseidon. So we start with my disclosure slide. In Poseidon, we were able to show that the combination, I will call it later on, the triplet of tremelimumab, durvalumab, and chemotherapy could demonstrate a statistically significant and clinically meaningful improvements of both progression-free survival, and overall survival versus the standard of care chemotherapy alone. It's well known, biologically speaking, that CTLA-4 inhibition is able to activate and expand the T cell population, leading to an increased T cell infiltration, while PD-L1 is sought to inhibit and overcome, PD-L1 inhibition is sought to overcome the T cell suppression, both happening at the tumor site. When we give chemo, we bring an initial disease control for sure, and we might also promote tumor antigen presentations through direct killing of tumor cells. While we have growing experience using immunotherapy, we also start to identify subgroups of patients who are characterized by a poor outcome under immunotherapy or substantially in general. Basically, STK11 mutated and KEAP1 mutated tumors are associated with a strongly poor prognosis, but they also have been shown to be what we called immunologically cold and lacking T cell infiltration. So KRAS mutated subgroup is slightly more heterogeneous and generally has been shown to be responsive to anti-PD-1 or anti-PD-1 based therapy, unless they are found to be associated with STK11 and KEAP1 mutations. So the idea was here to explore the outcome from Poseidon of this mutation, STK11, KEAP1, and KRAS subgroups of patients. So this is just a reminder about the Poseidon trial design. This is about naive patients with no ALK or EGFR mutations who are stratified by PD-L1, more or less than 50% histology and stage, who are randomized in 3 treatment arms, a standard up to 6-cycle platinum-based chemotherapy, and 2 experimental arms. One is giving durvalumab with 4 cycles of platinum-based chemotherapy, using durvalumab in maintenance until progression. And the second experimental arm is giving 4 cycles of chemotherapy with tremelimumab and durvalumab, an additional cycle of tremelimumab, and followed by durvalumab until progression. Primary endpoints were PFS and OS for durvalumab plus chemo versus chemo, but alpha-controlled secondary endpoints were composed by PFS and OS for tremelimumab, durvalumab chemotherapy versus chemotherapy. So basically, this is a long version of the slides. Now, don't worry, I will try to do fast because you have put me here the long one. So it's fine. Okay. So I will make it short. So I will summarize here. In the population of interest, which is the non-squamous for STK11, KEAP1, and KRAS, you can see here that the patients who provided tissue at baseline and plasma at baseline were mainly evaluable for this biomarker. 96% of them, meaning 612 patients, were evaluable or in the plasma, or in the tissue, or in both for these alterations. And the prevalence on the right-hand side is corresponding to what we know from previous data sets: KRAS mutant in 30%, KEAP1 in 6%, and STK11 in 14%. As you can see, there is some overlap, and while we observe some overlap and co-occurring mutations, these subgroups become very small. So we will not be able to deliver the outcome of these co-mutated tumors because of the sample size issue. So let's focus on STK11 to start. We're able to see an overall survival benefit trend for durvalumab, tremelimumab, and chemotherapy in this patient with STK11 mutation, hazard ratio 0.56, and importantly, at 2 years, an estimated survival of 32.3 months for the triple therapy as compared to 4.5 for the chemotherapy arm. If you look at the PFS, it matches the overall survival data with a hazard ratio of 0.7 for tremelimumab, durvalumab, chemo versus chemo. And as you can see at the milestone at 1 year, 34.6% of the STK11 mutated patients still being progression-free, while there was none in the chemo arm. But to me, the most important piece is the right-hand side, the spider plot. If you look at the spider plot, in both experimental arms, you can see a higher response rate, a more important depth of response, and a more durable, a longer durability of the response. And this is particularly true. We have the highest response rate, the more important depth of response, and the longer duration when you look at the tremelimumab, durvalumab chemotherapy arm. If you look at this, you can even see that there is one complete response, which is always quite symbolic in immunotherapy. Importantly, the depth of the response was deeper and deeper after each cycle of chemotherapy in a continuous manner, with an overall response rate of 45.2% and a median duration of response of 13.6 for this triplet therapy in this specific subgroup. Okay, let's look at KEAP1. KEAP1 mutants were quite rare, and we decided to evaluate KEAP1 mutation in the all biomarker evaluable population, adding there 14 patients who had squamous histology or other histologies and non-squamous. You can see, be careful, it's always small sample size. We can again see in this subgroup an overall survival benefits trend with a hazard ratio of 0.43 and a landmark at 2 years of 35% overall survival for the triple therapy arm, while there were no patients in the chemo arm. Down the slide, you can see the specific non-squamous population we were targeting with a hazard ratio of 0.33, but again, be very careful about the small numbers. Looking at the PFS, maybe we can just look at the landmark. We have patients free from progression at 1 year and 30% in the triplet therapy, while there were no in the chemotherapy arm. But again, the most interesting is a spider plot, when you can see that the depth of response, the response rate, and the durability of response is the best in the triple therapy of tremi, durva, and chemo, with a response rate of 45.5% and a duration of response of 16.4. Last but not least, a large group of KRAS mutants. We could find again an overall survival benefit trend for tremelimumab, durva, and chemo, hazard ratio 0.56, and at 2 years, 51.7% alive in the triple therapy arm, 25.6 in the control arm. Again, I have a look also at the durva chemo arm, which is in terms of efficacy, almost sitting in between the two arms. I always quote the triple and the chemo arm. This is perfectly in line with the PFS, where you can see this hazard ratio of 0.57 for the triplet versus chemo, and patients free for progression, 40% in the triplet, 20% with the chemo, and very, very, I would say, obviously and visible depth of response, response rate, durability, with an overall response rate of 55% is favoring the triplet therapy. The median duration of response is still not met in this patient population. As a conclusion, we were able in this exploratory analysis to demonstrate this trend of overall survival in this patient population who are characterized usually by a poor outcome and a poor response to immunotherapy, this STK11, KEAP1, and KRAS mutant non-small cell lung cancer. We could see it as a trend for OS, also for PFS. In this subgroup of patients, the most interesting to me is to see the most frequent and deeper responses, including complete response and a sustained disease control. Just look at this response rate, 45.2 for STK11, 45.5 for KEAP1, 55 for KRAS. So really speaking about a kind of a salvage or maybe a rescue in the efficacy of what we do. This data suggests that it might be a strategy to adopt for these specific subgroups in the future and maybe further validate. This is to acknowledge also all the patients and the collaborators in a huge number of sites in 90 countries, and of course, patients, families, and caregivers. And thank you for your attention.
Superb data. Thank you very much. So next, we're going to cross one of those taboos in lung cancer that we don't often talk about, sexual health. And I'm really thrilled to introduce Dr. Narjus Flores, who's going to give her study, Sexual Health Assessment in Women with Lung Cancer, the SHAW study. Dr. Flores has really been a champion in this space, I think, and gone where others have been reluctant to go. She's the Associate Director of the CCEP and Thoracic Oncologist. She's a thoracic oncologist at Dana-Farber Cancer Institute and Harvard Medicine. She's also the co-founder of Latinas in Medicine and the founder of the Flores Lab, as well as the host of our IASLC podcast.
Thank you, everyone. It was quite different to be this side instead of that side in the last few days. We're going to summarize the results of the SHAW study. The SHAW study is the first sexual health assessment in women with lung cancer. These are my disclosures. Most of the data regarding sexual health in women and men with lung cancer precedes the approval of targeted therapy and immunotherapy. In addition, the majority of the studies that are dated as early as 1999 focus mainly in male patients, as the disease has been attributed more to be commonly in men, when in fact we don't know. That's not the case. Sexual health is underreported and understudied. One of the honors is to work with a multidisciplinary team. The SHAW study was designed before the pandemic, during the pandemic, and we pivot. The study was originally planned to launch in May of 2020, but we were able to modify the study and move forward. Some of the things that we're extremely proud is to have a multidisciplinary team, which included a certified sexuality counselor, OBGYN doctors, members of the GO2 Foundation and Longevity, as well as 2 excellent patient advocates that review every little piece of the protocol, including the logo before launch. This is an observational cross-sectional international study that was housed at the Lung Cancer Registry of the GO2 Foundation for Lung Cancer. We use a validated questionnaire, PROMISE, specifically the sexual health assessment of this validated questionnaire. The questionnaire has been validated in all patients with cancer, but a minimal number of patients with lung cancer. So what are the results of the SHOW study? Despite the challenges of discussing and having a study that is taboo in oncology about sexual health and a world pandemic, we were able to recruit 249 women. The range for age 29 to 34, and their average age was around 59 to 60 years. 88% were white, the non-Hispanic white, the majority had adenocarcinoma at 81%, and 41% of the patients were currently taking target therapy at the moment of the assessment. The results are sobering. This is a question that should have been asked many years ago. 77% of the patients in the SHOW study reported moderate to severe sexual dysfunction. So what this means? It means that these women's sexual dysfunction is affecting their daily life. They often think about the lack of sexual activity on the daily basis. And I want to stop here to remember that sexual health and sexuality and intimacy is not only about penetrative intercourse. This includes self-stimulation and masturbation. This includes kissing, cuddling, other forms of intimacy, which includes massage, for example. It is time to think that sexual health is only about penetrative sex. Our patients can have intimate sexuality in many ways. And still 77% of them have moderate to severe sexual dysfunction. Out of the 127 participants that had sexual activity in the last 30 days, 59% of those reported significant issues with vaginal dryness and 26% with vaginal pain, discomfort during sexual activity. We have many comments about postcoital bleeding that was often not discussed with their oncologist or primary team. We asked questions before and after lung cancer diagnosis, and significant difference were noted. There was a decreased interest or desire for sexual activity before and after lung cancer diagnosis. Vaginal pain and discomfort was significantly different between before and after. We control for confounding aspects like medications that affect sexual health and the history of mental health disorders before the diagnosis of lung cancer. So what is important about the SHOW study, it reminds us we cannot extrapolate data from other cancers to lung cancer when it comes to sexual health. We often extrapolate data from breast cancer. It's a very different cancer, it's a very different mechanism, and the therapies are night and day when it comes to sexual health. We do not use hormone deprivation therapy in lung cancer. So the number one cause that patients reported that was affecting their sex life very much to somewhat was fatigue, something that we often kind of brush off. Feeling sad or unhappy. Issues with their partner, which are also associated with sexual health, is a vicious cycle. If there's lack of communication, lack of intimacy is associated with partner issues. And very importantly and highlighted is shortness of breath. When you look at other studies about sexual health, shortness of breath is really in the bottom if we mention, but in lung cancer really matters. And there are interventions that can help our patients have intimacy while dealing with limited lung capacity. What is your take-home message from the SHOW study? Sexual dysfunction is prevalent in women with lung cancer at 77%. Additionally, sexual health should be integrated into thoracic oncology care now, not tomorrow, now. Further research is necessary to develop tailored interventions for patients with lung cancer. We cannot continue to extrapolate data about sexual dysfunction to 3 women with lung cancer with sexual dysfunction. The Flores Lab is working in developing a multidisciplinary intervention that will go for addressing shortness of breath with teaching our patients the adequate sex positions with limited lung capacity to understand the difference between vaginal lubricants and vaginal moisturizers. This is the take-home message for you. It's time to talk about sexual health and lung cancer. We want to acknowledge our study participants that in the middle of our pandemic, took time to answer this lengthy survey that often brought different types of feelings about their sexual health. It is a hard survey to answer. You have to do a lot of introspection, especially for patients that are not sexually active. I would like to 10 co-investigators, Ivy Elkins, Jeet Feldman, and Amy Moore. They believe in this idea in 2019 when we met in Barcelona for the first time. And they were so comfortable talking about vaginal dryness since day one. The University of Wisconsin, who gave me my first job, the GoTo Foundation, the Dana Cancer Institute, and to all of you for listening and taking action starting today. Thank you.
Thanks, Dr. Flores. Thanks for that call to action and for being such a champion for our patients. I'm pleased to present our next presenter, Dr. Belinda King-Calimanis, who will present informed consent forms for lung cancer clinical trials may be a barrier to enrollment. Dr. King-Calimanis is responsible for Longevity's patient-focused research center called Patient Force, which serves as a bridge to connect the patient voice to healthcare professionals, regulators, policymakers, and drug developers to ensure that patients are heard and incorporated into decisions. We're looking forward to your talk.
Thank you. So today I want to present the first 2 phases of our project to create this patient-centric addendum to clinical trials. These are my disclosures. So, as I said, this is a multi-phase project that we're carrying out. And to start us off, we wanted to really understand the problem with informed consent forms systematically. We all get a sense that they're complex and long and use jargon in use a lot of medical jargon, but what we wanted to do was look at a large number of them to really understand where the problems were. So what we did is created a matrix to look at the Code of Federal Regulation guidelines for informed consent forms and compare the forms we received to those requirements. But we weren't looking for compliance. We were just looking to understand how these critical pieces of information were being presented to patients. After we did our review, we conducted focus groups and interviews with patients, some who had been previously or currently on clinical trials, and in other patients who were at least open to the idea of participating in a clinical trial. Coming up, we will speak with other stakeholders to learn about their perspectives on what to include in the addendum, and ultimately we'll create a hypothetical trifold to cognitively debrief with patients and caregivers so that we can further refine the trifold, and then I'll get to those next steps at the end. But just to give a snapshot of the trial ICF demographics, they did cover a wide variety of, they covered across the entire drug development life cycle from phase 1 to 3, including a single patient IND. Most of them were from advanced non-small cell lung cancer, but we did have forms from small cell and some targeted therapies as well. And trials were just over half of them were global. So what did we find when we reviewed the informed consent forms? We did indeed find that they're very lengthy. So on average, 21 pages with a range of 15 to 34. They were organized in a Q&A way most of the time, with the question being the header and then the answer in the text. Some used a descriptive approach to describing the information, and some used both. But the reading level was on average at 10th grade. And so we actually even tried to help that out and made sure that we didn't include words like chemotherapy. We changed those to simpler words so that we weren't getting dinged on complex terms that have to be in the informed consent form. And even in doing that, we found that the average reading grade was 10.3. And in the US, we look at trying to be more like 6th to 8th grade reading level. What I found particularly surprising was when we looked at where the information was placed in the informed consent form, that foreseeable risks were in the second half of the informed consent form, not in the first half. So by the time you get to page 10 of that form, you've got so much information floating around in your head. The foreseeable risks, I'm not sure how you can process that, but in some of the forms we read, the mechanism of action for the drug was up front on page 2 of the informed consent form. Now, some patients are going to find that really interesting, but for most people, that's additional details, and that could certainly be saved until the end. And then the final thing is just looking at compliance, and most of the informed consent forms covered all areas. What you might pick up here is seeing that when the trial fails was not always being presented. That's more of an artifact of the fact that we had trials that were ranging from phase 1 to 3 and also a single patient ID. So what did we find in the focus groups? Patients were pretty clear in their directive on what they wanted us to include in that form. So they wanted a clear explanation of the criteria to qualify for the study. That particularly was a priority for those who had already participated in clinical trials. They wanted to note that the study was indeed optional. What is being tested and what can the patient expect as treatment? They wanted a clear explanation of that, because sometimes it wasn't really clear what the standard of care arm was offering them. Where's the trial happening? Is it happening where they have to travel, or can some things actually be done locally for them? They wanted information about their privacy, how it would be protected, how the drug's going to be administered, how frequently, and the duration of the study, and then importantly, what comes next after the treatment ends. So one patient said that they'd like a section for eligibility. So what kind of things would make you eligible for the trial and what things might not make you eligible? So if you see the list and you're not eligible, you can say, I'm not reading the rest of this form. So as far as how the format was to be laid out, patients wanted to see it in bullet point format. They wanted page numbers to reference key details. So for example, they didn't want 20 side effects printed on this 1 to 2 page addendum. They wanted a snapshot of the most common side effects, but then a reference to tell them, and on page 10, they could find that lengthy table telling them all the potential side effects and sort of use it as a cheat sheet to the informed consent form almost. And so also contact information, you'd think that that would be all in one place in the informed consent forms, and it wasn't actually. So they wanted all the different people, so whether it was for IRB issues or injury issues, just to be listed who was who in one spot and not have to flick through the 20 odd pages. And then just information that is provided really clearly to them. So in summary, we found that consent forms are really long indeed and written at an 8th grade reading level. And the patients endorsed the idea of adding an addendum summarizing that most important information. And we really feel there's an enormous opportunity to become patient-centric in the content and use of language in these forms, but we're not looking to really fix the informed consent forms, but these lessons that we've gained from this work can certainly be used there by different drug companies. But we feel that by adding an addendum, that's something that we can also, that longevity, we can provide the template. And our next step beyond this project is to actually implement it into a clinical trial where folks are randomized to receive informed consent form as per usual and using the trifold, and then assess both from the patient perspective as well as trialists how these forms are working. So I'll just finish with a patient quote who said that during one of our focus groups, it was lengthy. When I first opened it up, I had mixed feelings because obviously lengthy means that it has a lot of information, which is good for me. But also, you know, the lengthiness was a bit overwhelming and made me a little bit anxious, I guess. That was my initial impression. Thank you for having me speak today.
Well, thank you so much. It's an incredibly important topic that we all need to pay more attention to. So thanks for bringing it to light. I'm pleased to introduce Dr. Charles Rudin, who's going to discuss his abstract first-line pembrolizumab or placebo combined with etoposide and platinum for extensive stage small cell lung cancer, the Keynote 604 long-term follow-up results. As you all know, small cell is one of the types of cancer we haven't yet sort of cracked, and Dr. Rudin and his teams have spent a lot of time thinking about this. I'm excited to hear this longer-term study.
Great, thank you. This has been great. I've actually learned a lot already this morning. What do I do to put my slides up? Oh, there we go. Great. So I'm going to present this a longer term outcome of a study. There was a first-line trial for patients with extensive stage small cell lung cancer. So this is a particularly grim cancer, as you've heard. This study looked at chemotherapy with or without an immunotherapy, the immunotherapy being pembrolizumab. Pembro has shown activity in small cell lung cancer in the recurrent disease setting, and this study was looking at it up front. The study was positive for progression-free survival. That is, the progression-free survival was better on the pembrolizumab arm with a hazard ratio of 0.75 and a p-value of 0.0023. However, it was actually negative for overall survival, although there was a good hazard ratio of 0.8 in favor of the pembrolizumab arm with 95% confidence intervals that did not cross 1 and a p-value of 0.0164. This is an updated data set now with about 3.5 years of follow-up of these patients. And I think in part this is important because we can learn from these studies that are actually statistically negative, but are informative for our patients if we continue to follow them. This is the study design. I won't belabor it. Happy to address those questions and a little bit about study disposition. Again, I won't belabor this further. There were 18 patients that completed the planned 2 years of pembrolizumab therapy, and we focus a little bit in the presentation on these 18 patients. I think the important take home from this slide is really that we can't call out these long-term benefiters by clinical parameters. Their age is the same as everybody else. You know, their split performance status exactly the same as everybody else. 3 of these patients had brain metastases at baseline. 3 of these patients had liver metastases at baseline. They really look clinically like everybody else. These are the updated survival curves now with most of the patients out past 3 years. Small cell lung cancer is a tough disease, and unfortunately, it remains quite lethal. But there is a tail on this curve, and there are real survivors out here past 3 years, particularly in the population that got pembrolizumab. And this is true really across the various subsets that we looked at, with the exception perhaps being patients who had brain metastases at baseline, although this is a very small cohort, too small to really interpret. To me, this is the more important take-home slide here. This is progression-free survival. And again, these patients stopped therapy after 2 years. And you can see that on the control arm, there's essentially no long-term progression-free survival on chemotherapy. But the patients who got pembrolizumab, there is a significant tail on the curve here. And of course, it's much lower than we would want it to be. It's in the single digits. But these are patients who are surviving long-term with extensive stage small cell lung cancer off therapy now for multiple years, living their best life and really off of therapy. And that's a real paradigm shift, I think, for us as oncologists. There's 20-fold improvement here in 2-year progression-free survival. My colleague Mark Chris likes to look at overall survival and progression-free survival, and he says, on the survival curve, there's patients who are fighting 2nd and 3rd and 4th line therapies and are in the hospice programs, and these patients who are remaining progression-free are really in a different class. They're not suffering relapses. That's important. This is a summary of the response data. The response data was actually published. The top part of this graph was previously published, but the duration of response data is new. And you can see again on the chemotherapy arm at the right, really very, very few patients remaining progression-free. In contrast, on the pembrolizumab arm, 10%, remaining with a duration of response over 42 months. So these patients are really doing quite well. Small subset, but important. Adverse events were as expected. There are some adverse events associated with immunotherapy. We know that, but there was really no safety signal, new safety signal on this trial. And these are the 18 patients who comprise the tail of that curve. These are the 18 patients who completed a full 2 years of pembrolizumab. 14 of these 18 patients remain alive as of last assessment and are continuing to be followed. So that's the deal. So 3.5 years of follow-up now. The patients who are on pembrolizumab, I think, continue to show clinically meaningful improvements in particularly progression-free survival, which I think I would emphasize here, as well as overall survival. There's about a tripling of the 3-year overall survival rate, about a 20-fold improvement in 2-year progression-free survival. Safety profile not particularly remarkable. And those patients who completed a full 2 years of pembrolizumab have durable responses, with the majority, 14 out of 18, remaining alive, now with about 4 years of follow-up after randomization. So I think, we need to continue to explore the benefits of immunotherapy in this patient population and see if we can build on the tail of that curve to raise it up to apply to more of our patients. So thanks very much.
Thanks, Dr. Rudin. Some really heartening data for a disheartening disease, but good to see the progress in that group of patients. As is our typical course, we'd like to conclude by turning over to one of our patient advocates. I'd have the pleasure of introducing Dusty Donaldson, who many of you know. Dusty is the founder and executive director of the Dusty Joy Foundation, and is also the co-chair of the Lung Cancer Action Network. She's been a long-term advocate. She's written books about lung cancer and patient advocacy. She has experience as a journalist and public relations professional. And we're really interested to get her thoughts on all the discussions today.
Thank you very much. Great presentations by everyone. And as a patient advocate, I'm very highly encouraged. I'm just going to comment briefly on all of your presentations, but probably the most on the first one. So as a patient advocate, I am encouraged to see studies looking beyond tobacco for lung cancer risk. Far too many patients are unaware of potential risk factors for lung cancer, including air pollution. My concern, however, is with, I know you studied the outdoor air pollution, but I'm concerned about the indoor air pollution, namely radon, which is the overall #2 cause of lung cancer. And in people who have no history of smoking, radon is the #1 cause of lung cancer. So this study did a deep dive into the environmental exposure history of these women. Overlaying radon measurements to this study could prove interesting and potentially add significant impact to others at risk for lung cancer. I would love to see indoor air pollutant radon data incorporated into this study. I understand radon was outside the scope of this study, but it begs the question, why? How can you determine that outdoor air pollution may have been a significant contributing factor unless you also analyze the radon levels from the homes where these women lived? Incorporating radon exposure into these patients' historical data would provide a more meaningful, insightful perspective and results. After all, there is little we can do about the pollution in the air that we breathe in the outside atmosphere. However, mitigating radon from a home is something relatively easy and inexpensive to reduce the risk of radon. But it was a good study. I think it could be much better if you can add the radon component. I would like to see further research to delve deeper into the potential cause of lung cancer in never smoking women. The KRAS study. So, after decades of being undruggable, I'm delighted to see, more progress for patients with the KRAS biomarker. This study continues to provide options to a significantly large patient population concerning the entire KRAS population, although I understand it's a very small portion that this might impact. However, I'm sure my fellow advocate, Terry Connerum, will be sharing this news with her KRAS kicker. So it's good news. The sexual health assessment was a fascinating study. Frankly, women with lung cancer, as was reported, may experience disappointment, frustration, and emptiness in their sex life. And frankly, if women are, then it stands to reason that so are their partners. 3/4 of the study participants reported little to no interest in sex. That's pretty shocking, actually. The question arises, though, to whom would I take this problem? Because I can say I would not be comfortable discussing this intimate subject matter with my oncologist. Not only would that be an awkward situation or awkward discussion, I want my oncologist to focus on the cancer. And yet, this is a problem that needs to be addressed. So I would like to see an oncology team, providers trained to be sensitive to this issue, to recognize that this is a potential problem and apparently a very common problem. A true multidisciplinary approach to oncology care would include resources such as a psychologist or a therapist available to the patient to help her and her partner work through these issues. Thank you, Isabel. So now the informed consent for lung cancer clinical trials, creating a barrier to trial participation. Just as a patient advocate, what can I say? This study could lead to the removal of barriers hindering patients from entering clinical trials. It has the potential to be highly impactful for patients and researchers and expand beyond the lung cancer realm. So longevity team, keep doing what you're doing. This is good work. And finally, on the small cell study, Dr. Rudin, I really appreciate your work here. Small cell lung cancer patients deserve better than the current standard of care, which is failing them more often than not. These results, impressive as they are, it's for a patient population that has been significantly underserved. So there's meaningful progression-free survival, and this study offers a glimmer of real hope. And I'm looking forward to sharing this encouraging news with our small cell patient group. Thank you.
Thanks so much, Dusty. Great summary of all the studies. So I think we're going to open it up for questions now. I don't know, Chris, if there were any online or but if there's anybody in the room who would like to ask any of our panelists a question, please feel free. There's a microphone in the back that can be passed to you. And maybe while you're thinking, I'll start. I think, we often have this idea that there's targeted therapy and there's immunotherapy, but in point of fact, Dr. Peters describes we're getting closer and closer to targeted immunotherapy. And I would just love to hear your thoughts on that, targeting agents, targeting it to different mutations that patients have. Are we moving towards an era where we're talking targeted therapy for every patient?
Yes, it has been also a wording issue over time. We started to speak about personalized oncology, and then it was kind of considered being abusive because anyway, we do personalized oncology, right? We try to personalize what we do to the patient. So it's, I would say, the definition of precision oncology. We've been developing, probably thanks to or due to the market and the pharma industry wanted to create the largest markets possible, strategies giving rise to positive results in unselected patients, with our clinical observation that there was a high variability in the level of benefit obtained in from one patient to the other one. The best example is EGFR mutant or non-mutant for gefitinib, right? At the time, Tony Mock was observing that some patients had absolutely no benefit, had horrible tumor growth, and some had wonderful benefits. So this holds true for all what we call the targeted therapies with actionable alterations being the target, but it also holds true for immunotherapy. Look at Charlie trial. Look at what I have been showing. Wonderful result, but still the percentage of patients having really a long-term benefit is a small percentage. So more and more we make it happen being larger, meaning we select better, but still we are not there. Half of the patients have no long-term benefits. So I think more and more by maybe going back, unfortunately, to the biological samples and to the biological questions, we'll be able to understand why we are giving which treatment to which patients. Unfortunately, we very often don't go the right way, right? We should know before, and usually we get to know after, and it takes some years. But we're getting there. At least the direction is the good one.
And Charlie, maybe I'll ask you as a follow-up to that. You mentioned that we can't call out long-term responders by clinical features. How close are we to sort of biomarkers for small cell, and sort of when can we find those patients who are going to be long-term responders?
Yeah, that's the key question, is who are these 18 patients, and how could you find them, and how can you apply the lessons learned there to the rest of the 95% of the patients that unfortunately did not benefit in that way? We're deep into the analysis of that right now. We don't know the answer, but we have on that study, patients were invested in the study. They participated, they provided tissue. We have those tissues for analysis, and that's going to be an incredibly valuable data set now to be able to call out what are the special features of those tumors that respond, and how could we apply those pathways to other tumors. So RNA sequencing analysis is ongoing right now. Eager to see the results of that, and we'll see. So stay tuned. We'll know more about who's in the tail of the curve soon, actually very soon.
Great, thanks. All right, Dr. Flores, I'm sitting here wondering the same, similar to Dusty. And so I consider myself to be a pretty touchy-feely surgeon, but for me, and particularly maybe for a female patient, it would be a tough subject for me to broach. And so what is the best way for that? Is it from the physician? Is it from an extender? How do you recommend these discussions?
So, I hear that so often, and we cannot put more responsibilities in our patients. They're dealing with a fatal disease, so they also have to bring out sexual health. I have it in my EPIC template, my note. It has financial toxicity, sexual health, and social work referral. It's just a quick paragraph. And I think we haven't received appropriate training. And as a surgeon, medical oncologist, surgeon oncologist, we don't get training on this. And that's unfair to our patients. And I often get asked, why is sexual health is so important? If you have addressed the sexual dysfunction, patients require less opiates. Some of them can go half. The pain is better. So I think it's our responsibility to address it. And there are many ways to address. But one of the easiest questions to ask, can we talk about sexual health? Can we talk about your sexual health? Some patients, I have the most crazy responses. I have ones where the husband stand out and left. I have one that I was completely on the fence, and this is not your problem, and that's okay. But then I continue to address it. I have women that start crying. I don't say anything else, like, let's talk about your sexual health. So it is a training, and it's like going to the gym. The first time you go to the gym, you're in pain, you have tachycardia. The first time you ask about vaginal dryness. I'm being very honest. Like the first time I did it because I wasn't trained. And as you continue going to the gym, it becomes a normal conversation. But I want you to know that I have patients that drive 11 hours to see me with stable scans, with stable disease. And I sit down and I say, how can I help you? The disease looks okay. What's going on? And this patient that came from Indiana told me, I came here because you are the doctor that talks about sexual health. So that's the need. Her cancer was doing all right. She had metastatic cancer, but she had to put resources, financial resources, to come all the way to see me because nobody have asked her that. So let's all go to the gym for the first time.
Yeah.
One of our incredible patient advocates who gave the opening address, Annabelle Gurwitch, has a question.
Hello, thank you so much to all of you and Dr. Flores. I just want to emphasize, so I have had no problem asking my oncologist about this issue, but unfortunately, the information has not made it to even oncologists in major cancer centers, that there can be a connection between sexual dysfunction and lung cancer treatment. And so in the conversations I've had with my oncologist and the team at for instance, where I'm being treated, Cedars-Sinai Hospital, and where I was treated before at UCLA Hospital, there was zero knowledge that this could have an effect. And so the patient advocate or client, as I like to say, is completely left on their own and told to go to their to their gynecologist, who probably, in my case, had absolutely no information on this subject. So if there is a way I can be useful, but I want to encourage everyone who is here to think about ways that this kind of information can get out to the more, I mean, if I live in Los Angeles and there's not that information, what about lung cancer patients in small rural areas or other parts of the world where this information isn't getting out? It's so important. It's such an important part to experiencing well-being and quality of life. And it is interesting. I did write in the Washington Post about the chronic UTI situation as a lung cancer patient, and I did not hear from any oncologists any response, as to this being a connection. This conference is the first time I have heard that, and I just can't even tell you how much I appreciate that and how important I think that is for this community that I belong to. So thank you so much. It's transformational to be affirmed and to know that you're doing that work, Dr. Flores.
One important thing to mention is it's not expected that the oncologist would be the expert, but it's expected that the oncologist would ask and do the referrals to the appropriate person. It can be one sexual cancer. We have a sexual dysfunction program at Dana-Farber led by Dr. Bover, and she guides a lot of things because every day I'm learning. Like I did this study and I'm learning so many other things. And that's what I think is important. There's a lifelong learning, and that sexuality doesn't have to be only two. The value of individual sexuality for our patients is also important. And self-stimulation should not be undergraded as no part of sexual health.
Dr. Flores, and maybe both of you, what I hear and what I realize also, it's wonderful to be able to discuss about it too, is a gap in education. Probably I'm old enough not to represent another generation than the current one, but I would guess that the education about this topic is not better than when I was trained, or at least not improved in a major way. So there's really an education gap. So one thing is to create awareness in order that in 1 or 2 generations, it's part of the medical school, or maybe it's to try to compensate for the gap. So we create modules, webinars, training slide decks for nausea, for pain management, for how to handle, how to speak, maybe also communication skills modules for any topic in oncology, but not this one. So maybe you should think about how you can engage societies, which I'm sure will give some money, some training, some support to really create the tools that any small school, whatever it is, can use to train the doctors, because we have to compensate for what has not been done. No?
And we're happy to do that. I think it's very important. One of the challenges of sexual health is the taboo around it. And when I talked to Dr. Bover, she's like, sexual dysfunction is hypertension. It's a disease. When you talk to the sexual counselors, I wish one day I can be as smooth as they are, because they are able to address these issues in a way and you don't feel guilty, you don't feel ashamed, and you feel heard. So we have so much to learn from them and bring that to lung cancer. It's time now.
Thank you.
Great. Well, thanks, everybody. And Dr. King-Calamanis, I'm sorry we didn't get back to you, but there are some really incredible questions, I think, to get to about consents and how consents are delivered. Have we got past just a big packet of papers? Should we be doing video consent? Should we be doing interactive online things? And I just quickly wanted to ask this, the last question. Were there any patient preferences for the way that information is delivered?
No, there wasn't really any preferences that were voiced. It was they really focused in on the information that they wanted to have to make an informed decision. Because we did, when we were first thinking about the project and talking to some patients, we heard patients tell us, I signed up for a clinical trial and I honestly didn't know what I was really signing. I just signed it because that was the only choice for a treatment that I had, and I couldn't process that information. It was too much. And I just went ahead and signed it and hoped for the best. And so that's not a situation you want to find yourself in. So if this is at first, maybe it is paper, but we certainly are interested into looking into, because everybody's a bit different, right? Some people prefer a piece of paper, some people want a video, some people want something else. Maybe we're certainly open to exploring alternative options as well to present this information.
Great, really important work. Yes, final comment.
When you were evaluating the consent, something I really struggle with is consent in other languages. Was that addressed? Because like I treat a lot of Spanish speaking and Portuguese speaking, but I don't have the consent. And sometimes that precludes them from recruiting in the study because it is not ethical to consent somebody and we are consent that is in English when they speak no English.
That's a great question. I mean, the trials that we looked at, we did get their English forms to look at. Some of them were set up so that you could see where information was being fed in from different countries for different IRB and regulatory requirements. But no, we have not explored that yet. But I think that's a really great point. Like, this is part of why people are being excluded, because there aren't options for language. So part two.
Super. Well, I think we're going to wrap up, but thanks everybody for coming. Please reach out to us if you want to get in touch with any of the panelists about further questions, and we certainly hope that you will. There's a lot of great information to unpack, but thanks for coming.